going to talk about how to define trauma and what it is, what makes sense from a psychological, psychiatric, diagnostic perspective. But before we do that, let's talk some about self-care. First of all, I want you to keep in mind that self-care is not the same as spoiling yourself. It's not going to the spa, getting your nails done, getting a new haircut, buying a new shirt, buying some new earrings. Instead, Audre Lorde says, caring for myself isn't self-indulgence, it's self-preservation. I think that last word, self-preservation, is really important. It's making sure that we are taking care of ourselves, putting the mask on before we help somebody else. Giacomo Marama talks about the difficulty in engaging in self-care and recognizing what it is, because our society is pretty consumer driven. And as a result, we commodify, depoliticize, and commercialize self-care. We're not sure what it means outside of Instagram influencers and Lululemon activewear. She says, I don't find it difficult to spoil myself. I'm good at consuming, whatever form it happens to be. Eating and drinking are favorite pastimes. I binge on entertainment. I buy more books than I can read. All of these things feel good for a time. However, these activities don't leave me feeling healed. And that's what we're working towards, healing. So let's think about what post-traumatic stress disorder means. We're going to be focusing primarily on Criterion A, this exposure to trauma, but we also want to be thinking in terms of intrusion symptoms. So what symptoms impact us and how we're thinking about things that we don't really want to think about, flashbacks, nightmares, intrusive thoughts, as well as persistent avoidance of those thoughts, or persistent avoidance of our feelings or certain kinds of situations. Criterion D is negative alterations in cognitions and mood, maybe more cynical, more depressed, more anxious, more just feeling like there isn't a future. Criterion E is alterations in arousal and reactivity. So hyper reactive, startle responses, maybe a lot of bodily tension, and that these things must go for more than 1 month if we're talking about post-traumatic stress disorder. If we're talking about less than 1 month, we're talking about acute stress disorder. There has to be clinically significant distress or impairment so that it may interfere with our ability to work or go to school or spend time with friends and family, or that we may do it in negative and maladaptive ways, and that these problems aren't related to a substance. So the DSM, the Diagnostic and Statistical Manual, has changed across time in terms of its definition. In the DSM-3, we are currently in the DSM-5, but in the DSM-3, it was seen as an event generally outside the range of usual human experience. That is a recognizable stressor that would evoke significant symptoms of almost everyone. Now, there are a couple of problems here. One is that it's pretty clear that many traumas are not unusual. 1 in 5 women have a history of sexual violence. And not everyone has the same kinds of symptoms, and they may not even be significant, at least at first. So in the DSM-3R, rather than saying it's unusual, the DSM-3R says it's a serious threat to one's life or physical integrity, serious threat or harm to one's children, spouse, or close relatives or friends, or a sudden destruction of one's home or community. You know, for example, tornado or hurricane, or seeing another person who's been recently or is being seriously injured or killed as a result of an accident or physical violence. So this recognizes that trauma can be common, but there's something serious about it. The DSM-4 says it has to have been experienced, witnessed, or that we must have, one, experienced, witnessed, or confronted an event that involved actual or threatened death or serious injury, or a threat to the physical integrity of self or others. And two, that there has to be intense fear, helplessness, or horror. Don't know why there are balloons here. So DSM-5 retains Criterion 1. It gets rid of Criterion 2. It says, we don't necessarily have to experience fear, helplessness, and horror. This remains controversial. And we'll talk about some of the ways that it's controversial. First of all, no longer DSM-5 Criterion A precipitating events include things like death of a loved one, witnessing an event, unless it's in person, violent or accidental death. Various life-threatening medical illnesses no longer, are included. So, for example, being diagnosed with cancer isn't a Criterion A precipitating event. However, waking up in the course of surgery and discovering that someone is doing whatever, that's seen as Criterion A. So does trauma better predict post-traumatic stress symptoms? That's what the second S refers to. It's not clear, so, and you can see that here in terms of our forest plot. There's not a real clear consensus. It's sort of, either way, and on, on the plot, not significantly better or worse. Larson and Pasella say their data point to the lack of crisp boundaries demarcating ordinary stressors from traumatic stressors, and the importance of individual perception in differentiating trauma from stressors. So post-traumatic stress symptoms were greater for individuals experiencing DSM congruent trauma. Okay, so Criterion A1. However, it's best predicted by both A1 and A2. Must be something about 2 that's causing those balloons to go up. And there's more self-reported, when there is self-report of a life threat, so A1, as opposed to what a rater thinks, that's significantly better at predicting. The short story here is it's confusing. We don't really know. And Chris Bruin and his colleagues come back to this and say, you know, frankly, any event or events that bring about a cluster of symptoms such as PTSD should qualify as a trauma. And there's something to be said about that. You know, it's not that I should be identifying what trauma is, but that trauma is in the eyes of the beholder. So let's approach this yet another way. Does Criterion A trauma better predict post-traumatic stress disorder and complex PTSD? So we're again looking at odds ratios, here with post-traumatic stress disorder, here with complex post-traumatic stress disorder. And what we see is that these Criterion A events are associated with PTSD. They're even more associated with complex PTSD. The same is true when we're looking at non-Criterion A psychologically threatening events. So we're seeing significantly increased odds ratios. All of these are significant for PTSD, but even more so for complex PTSD. Sexual assault by a parent or guardian or by a non-parent or guardian predicts PTSD, but significantly predicts complex PTSD. And finally, we're seeing this difference here again, that there is this strong relationship between non-Criterion A events and complex PTSD. These are ideas that are complicated. We'll keep coming back to them. And, you may just need to be thinking about this on more than one occasion. So I'm going to stop here, say take care, make sure that you're taking care of yourself if you can, and take care of the people around you. Be well.